Hi, everyone. Ooh, sorry, didn't realize this was going to be that loud. Thank you all so much for joining us this evening. My name is Kathleen Benevento. I'm the Executive Director of the Navigator Program at Waveney Life Care Network. For those of you who are not familiar with this program, we provide 24/7 support, education, and guidance to care partners of people living with Alzheimer's and other types of dementia. This is a local community program. It is a grant-based program, so there's no cost to sign up for Navigator and to utilize our services. We have a great team of dementia specialists. They are experts and clinicians, and they're really there to support the people that we work with. We also have an adult day program that is exclusive for our Navigator clients at Waveney Life Care Network. So if anyone would like more information on the Navigator program or any way that we can help or support you, there's a sign-up sheet on the table. There's also some information over there, but you can come find myself or my team after the talk. So I now want to just first point out, because I did say I would mention there's exits on both sides, just in case anyone needs them. And this would definitely be a great time to silence any cell phones before our presenter starts to speak and talk on the topic for tonight, which is the basics of cognitive decline and the link to depression for older adults. So our presenter tonight is Dr. Stephanie Towns. Dr. Towns earned her doctorate in psychology at Antioch University New England. She completed her internship at James A. Haley, Virginia Medical Center, VA Medical Center in Tampa, Florida, and her postdoctoral fellowship in neuropsychology and brain imaging at Dartmouth Hitchcock Medical Center. She is currently an associate professor of clinical neurology at Yale School of Medicine and the neuropsychology division training director. So I would like to turn it over to Dr. Towns. Thank you.
Hi, everybody. Can you hear me okay? Let me know. So I'm really excited to be here tonight. I really love doing these sorts of community-based talks. I'm going to try and provide you all with some education and sort of basic facts about cognitive decline in older adults, some of the things that can cause it that are not dementia, some ways to prevent it, some ways to reverse it, and then we're also going to talk a little bit about sort of dealing with dementia and also how to access the different levels of care. So I designed this to be answers to some of the most frequently asked questions that I get every day in clinic. So some of it might be familiar to you, but hopefully it's helpful. So I just want to start with some definition of terms, because you would be shocked at how many people when we use certain terms, they either don't know what they mean or they think they mean something else, or we're using them one way and you're using them other ways, or God forbid, you Google something and you get all kinds of definitions. So cognitive impairment. So I just want to talk a little bit about cognition. It's a term for all your thinking skills. So 99% of the time when people come to see us, they talk about memory problems. And I would say about 70% of the time, it has nothing to do with memory. It's often another cognitive problem like difficulty paying attention, difficulty with language abilities, visual abilities, executive functioning, which is things like decision making or problem solving. And you can see up here, this is just a model of cognitive functioning that I love so much because it reminds you how much goes into a simple task. So if I were to ask you to repeat 3 words to me, memory task, right? Absolutely not. So first of all, you have to have the sensory input. You have to be able to hear me, right? So that means your ears have to be working. The part of your brain that interprets auditory information has to be working. You have to speak the language that I'm speaking. You have to have a conceptual representation, right? So if I ask you to remember the words rose, dog, and pencil, but you don't know what those words mean, you're not going to remember anything because they have no meaning for you. In a lot of senses, we need, the best ways to remember things are to organize them. So put them into categories, or I'm sure many of you have seen or heard about the strategy of like put each thing in a room of a house, or group them together, or so all of those things involve your executive functioning. Then I want you to repeat it. So you do have to remember it, right? Memory. We tend to remember things that matter to us, so emotion gets involved there. So if I give you a list of 3 words and you don't want to be there and you don't care about this evaluation and your kid made you come, you may not remember those words, and it may have nothing to do with your memory. But then also, if I'm asking you to repeat those words back to me, I'm using that as a measure of how much you remembered. But if you have difficulty forming your words, if you have a motor problem that makes it hard to move your tongue, your lips, your throat, all of those things can prevent you from responding back to me. And it can appear like you didn't remember, when in reality, it's actually a motor problem. And then I love the bottom part, because also you have to be awake and paying attention to me, which you would be shocked at how many times people can say, I don't know, they seem so confused. And if we sit with them for about an hour, they'll start to nod. And it's like, well, they may not be confused. They may not be awake. So this is just to highlight how many different parts of cognition are involved in what we commonly think about as memory, which is the most common presenting problem. So some terms for cognitive impairment. Some of you may have heard the terms for minor or major neurocognitive disease. This is sort of the current diagnostic language for cognitive impairment from any cause. So it can be reversible, it can be temporary. You can have minor neurocognitive disorder as a result of a traumatic brain injury. You can have minor neurocognitive disorder as a result of a stroke. You can have major neurocognitive disorder as a result of an HIV infection. But the important thing to keep in mind is sometimes these get used, especially major neurocognitive disorder, will get used interchangeably with dementia, and it's not necessarily the case. A delirium is an acute cognitive impairment that's due to something that's treatable and reversible. So infections, toxic exposure, medication side effects. So if any of you have an older relative who seemed super out of it and you were concerned it was dementia, and then it turned out it was a UTI, that's a delirium. And again, it's really, really important that we think these things through. I actually have, my own grandmother is 100, lives in the house that her great-grandmother built with stairs, God help us. And she had tested negative for her UTI, was super confused. They were like, well, this is it, this is the end. And the aide had been misadministering the antibiotics, so that it had never been treated. And we didn't know until somebody got out there and figured it out. So it's always really, really important to know the difference between an acute cognitive impairment that's due to something that's very reversible and treatable versus a dementia. A dementia it's an umbrella term. It describes all the syndromes that are neurodegenerative. So these are things that typically occur in older adults. They cause irreversible cognitive and functional decline. There are lots of diseases that cause dementia syndromes, the most common of which is Alzheimer's disease. But you can have dementia caused by Parkinson's disease, Lewy body disease, vascular disease, HIV. There's lots of different things that can cause a dementia syndrome. And most people, believe it or not, don't have just one. Most people who have dementia have a combined pathology. They usually have more than one. So we talk about them as if they're very separate things, but then when we do autopsies, we usually find pathology from more than one type in the brain. Mild cognitive impairment. So this is a term that's used, it is the original term for minor neurocognitive disorder. It was designed to describe cognitive impairments without functional impairment. So basically, someone who has a little bit of memory problem, they need help with their meds, they need help paying their bills, but they're generally okay. They can take care of themselves, they can live on their own, they can drive, all that good stuff. I stopped using this term because now, if you Google this, Alzheimer's disease will come up on your screen. And so now you more often see it as a term used for the early stages of dementia, specifically Alzheimer's. But you will still sometimes see clinicians who use it as what it's intended to be, which is this person has some cognitive impairments that may or may not be degenerative or reversible, but it's not really impacting their functional abilities. So I always like to let people know that if you see MCI in a chart or you hear that term from a doctor, it does not necessarily mean that they're talking to you about a dementia process or an irreversible process. All right, so how do we assess cognition? If you think about assessing cognition through self-report, so asking the patient. So if I were an orthopedist and you came into my office and said, my knee hurts, great, I'm gonna move your knee this way, I'm gonna move your knee this way, and you're gonna be like, that hurts, that doesn't hurt, right? How do you figure out what hurts? Your brain tells you. Pain signals go up to your brain interprets them, and tells you where the pain is. In the case of cognitive problems, if the brain is the thing that's not working, we are notoriously bad at self-reporting cognitive problems. Almost every study tells us if someone comes in to you and says, my memory is terrible, they probably do not have dementia. The people who have dementia come into you and say, I don't know why I'm here, this is nuts. There's actually a clinical term for it, it's called anosognosia. It's literally a symptom, and it's the lack of awareness of deficits. But the moral of the story is we can't really use self-report to diagnose cognitive problems, because the thing that we're trying to diagnose is also the thing that's responsible for reporting the symptoms. So many of you are probably familiar with cognitive screeners. This is the famous 30-point test that the president took. They're designed to be brief measures of cognition that can be completed in about 10, 15 minutes by a physician, a nurse, a PA, in a clinical setting to determine the presence of possible impairment. They are not designed to be diagnostic. They are not particularly specific or sensitive. What that means is if you have very subtle cognitive impairments, they're probably not going to show up on one of these screeners. If you have some mild memory issues, you can do the 5 words in 3 minutes, right? But if I give you 16 words in 20 minutes, you may have problems. Also, if you have a really hard time with the screener, very possible that you have very severe cognitive problems. They're also extremely sensitive to things like anxiety. So if you're really worried and somebody says, okay, here's 5 words, okay, repeat them back to me, okay, give them back to me in 5 minutes, and you go, I don't know, you just failed the test. They're also extremely sensitive to any sort of variation in race, ethnicity, language background, and they're supposed to be used very differently across age ranges, but people are often taught to use a single cut point. So, for example, I actually had a student in my office today, and she said, well, this patient had cognitive impairment on her MoCA. How come? Well, she had a 24 out of 30. Okay, what's the cutoff? 26 out of 30. Not for someone who's 85. That's a great cutoff if you're 55, but you shouldn't be using the same cutoff. But you'll see it again and again that people will say there's one number for everybody regardless of race, ethnicity, age. Not true. So they are extremely valuable tools for figuring out who needs more follow-up, but they are not diagnostic. Cognitive testing is the administration of measures across all of the cognitive domains. So that nice little picture that I showed you with attention and memory and language and visual abilities and executive functioning, that's cognitive testing. Neuropsychological evaluation, which is what I do, uses the cognitive testing and integrates it with all your other medical testing results, labs, brain imaging, EEGs, behavioral observations during an appointment that's pretty long, reports from the patient, reports from their families, in-depth review of medical records. We take all that stuff and we put it all together. And so that's sort of like, if you needed to get the most in-depth look at your cognition and medical history and put it all into context, that's when you would see me. And we're going to talk a little bit about when it's appropriate to see neuropsych and when you probably don't need us, because as you can imagine, that process takes time. And so a lot of people don't want to do it or can't spend the time to do it. So we try and avoid making you do it if we don't have to. So all of that was just to go through a bunch of different terms that I want to make sure everybody's on the same page about. This is the last one. This might be well known to all of you, but I do get a lot of people in my office who get confused about this. So who are the different doctors who you might see who might look at your thinking abilities? The neurologist. So this is an MD who specializes in the assessment, diagnosis, and treatment of neurological diseases, so diseases that impact the brain. Psychiatry. Also an MD, went to medical school. They specialize in assessment, diagnosis, and treatment of psychiatric disorders, so things that impact mood, personality, and behavior. So already you can see there's crossover a lot of times in these two populations, right? Because you can have a neurological disease that impacts your mood, personality, and behavior. So you may present to psychiatry, and it turns out it's actually a neurology case. You may present to neurology, and it turns out you actually have. So one of the reasons for the focus on depression in this conversation is that one of the most common differential diagnoses for older adults is dementia or depression, because the two look so similar in older adults. So you will very commonly get someone referred to neurology who probably actually needs treatment for their depression. Geriatrics is a sort of like a primary care doctor, but who specializes in the treatment of older adults. So they will often serve as your quarterback. And one of the reasons to have a geriatrician as opposed to a different type of primary care doctor is that they're usually, and the ones that I work with truly are, amazing at navigating the systems that are unique to older adults. So the geriatrician, my favorite geriatrician, the first time she meets somebody, you're talking about power of attorney. She wants to know where the support systems are. She wants to make sure you have a med list. If you don't have a med list, she's going to give you a card to write your med list, right? They sort of are focused on the systems that support older adults very specifically. A psychologist is a PhD, so not an MD, who specializes in the treatment of psychiatric disorders, right? So they work with psychiatry. They treat the same sets of disorders, but they treat them using behavioral treatments. So that's who does things like talk therapy, health psychology interventions. If anybody's had a heart attack and had cardiac rehab, that would be a psychologist, all of those things. And then neuropsychology is a PhD trained in psychology originally, who then goes on to do additional specialty training in the assessment of brain-behavior relationships. Ta-da, that's me. Any questions about all these definitions? I know I'm supposed to wait till the end, but I'm happy to answer questions as we go. Okay. So hopefully I've given you a nice foundation to understand a lot of the terms that I'm using and to sort of navigate the healthcare system. But let's talk a little bit about some of the most common causes of cognitive impairment in older adults. And the reason I think this is so important to talk about, and I don't know if any of you or any of your loved ones have had this experience, but I swear you hit 70, you go to your primary care doctor and you say, man, I am losing things left and right. And they're like, dementia, Aricept, here you go, goodbye. There's definite, and I also have patients who will come in and be like, well, my memory is going, I'm in my 70s or 80s, it must be dementia. And the reality is that is not the case for so many people. There are a ton of common causes of cognitive decline that are not a dementia process or even necessarily a neurological disease process. So one of the things to keep in mind is that just like your body, as you age, your brain becomes more sensitive and vulnerable to changes in the system. So just like if you were in your 20s, you could stay out all night, drink, get up the next morning, run a 5K, and then go to work. Cannot do that in our 80s. Our bodies will not respond in the same way. Same thing goes for your brain. So in your 20s and 30s, you may have been able to deal with tremendous amounts of stress, distraction, kid raising, working, parents, and you could just sort of hold it all together. But once you hit your 60s, 70s, 80s, 90s, those things start to take a toll and your cognition actually becomes much less efficient. So like I said, one of the major differentials, one of the things that very commonly is mistaken for dementia is depression in older adults. And that is because the two look so similar. The presentation can be very, very similar, and it can actually be really hard to tell apart. One of the other things that we don't always talk enough about is pain. As you get older, you have a lot of orthopedic physical problems, right? If your brain is constantly being hit with pain signals, of course it is not functioning efficiently, right? The whole system is designed so that pain interrupts what you're doing and alerts you to the fact that there is a problem. That whole system is designed to stop you in your tracks, distract you from what you're doing. So if you have chronic pain or frequent pain, it's going to continually do that. And you're not going to be able to pay attention, stay focused, remember things, finish your conversation, come up with your words. Sleep problems. So if you didn't Google me, this is my area of research. I'll talk about this all day. But sleep is really, really important for brain health. For those of you who don't know, while you are sleeping is when your brain clears out the pathology that causes Alzheimer's disease. So if you don't get a good night's sleep and go through all the stages of sleep, your brain literally cannot clear out those plaques and tangles. So people who don't sleep well, we find higher levels of Alzheimer's pathology in their bloodstream. Sleep is huge. It will also just cause, again, day-to-day cognitive problems. When you were younger, you could not sleep, you could bounce back, it was fine. Not as you get older. Normal aging. Normal aging comes with cognitive decline. So everyone in here is going to, has, and will experience declines in their cognition as they get older. The reason that my job exists is because we need to be able to distinguish between what is normal cognitive decline for aging and what is not. So when somebody comes in and says, I was not like this 10 years ago, me neither, man. Fortunately, it's part of the deal. And it's good to get it checked out and know whether that rate of decline is just sort of getting older or whether there's a problem. This is one that gets ignored a lot, menopause, for all the ladies. Anytime you're going through any sort of major hormonal changes, so they've actually found that young women who have breast cancer who get thrown into menopause in their 20s and 30s as a result of the treatments will have cognitive changes similar to those of women in their 50s and 60s going through menopause. So there's very real cognitive changes that happen with that process. Medication side effects. Medications that you took when you were younger have a very different impact as you get older. One of the specialties that I didn't talk about in my little doctor slide was geriatric psychiatry. So we talked about geriatricians, we talked about psychiatrists. There's also such a thing as a geriatric psychiatrist, which is a psychiatrist who specializes in giving psych meds to older adults. The reason that that job exists is because a lot of those meds have a vastly different impact as you get older. There's also a lot of, in particular, the psych meds and sleep medications. Somebody who has been taking Ambien their whole life and had no problem with it, as they start to get older, could really start to have problems as a result. Any sort of vitamin deficiency. So again, the whole system is sensitive to infections. We already talked about UTIs, but also things like B12, thiamine, all those things. Getting your blood pressure, your blood sugar, right? Anything in your system that gets out of whack can start to cause cognitive inefficiencies that can look very scary to the people around you and for you. And then, of course, substance use and abuse. I would be remiss if I didn't bring up the new love of marijuana. We do not know what marijuana does to older brains. We do not have a lot of research where older adults in their 70s, 80s are consuming marijuana products. There are definite risks that it can cause an acute delirium. I had a patient who, she was living in California, doing fine, loving her life, lived with a grandchild, got dementia, daughter moved her back to Connecticut because she had dementia, she needed to leave, she was devastated, had to leave her family, had to leave her friends, had to leave the life she'd built for herself, came back and saw me and the dementia had cleared. It turns out the grandson's girlfriend was giving her gummies at night to help her sleep. Benignly, right? They don't do anything to the 20-year-old girlfriend. So she thought, like, if you have trouble sleeping, of course this would help you. And it had caused kind of a delirium. And they didn't figure it out until she got back, and I was asking some questions and was like, well, what has changed? And it was the gummies. So that won't happen to everybody. There's plenty of people for whom marijuana can be helpful, but do not self-prescribe, do not self-take. Please work with a doctor. But then also any other sort of substance use and abuse, any sort of, alcohol, other medications, all those things. Please? You're good. Melatonin's a naturally occurring substance in your body. So when you take melatonin, it's just sort of extra cueing your body that it's time for sleep. Good question. So these are all common causes of cognitive decline. A lot of them are also risk factors for dementia. So for example, having depression can cause cognitive problems. Having untreated depression also raises your risk of dementia by almost double, 1.82 times. Same thing is true for untreated sleep apnea. Untreated sleep apnea literally shrinks your hippocampus. Your hippocampus is the part of your brain that's responsible for memory. It is very oxygen hungry. It is the first thing to get hit when you don't get enough oxygen. Untreated sleep apnea deprives you of oxygen overnight, so your hippocampuses will shrink and you will have memory problems. If left untreated, it will also greatly increase your risk for both strokes and almost every type of dementia. Good news is, treatment will reverse it. So if you start wearing a CPAP 4 hours a night, 3-4 months, your hippocampus plump back up. Hippocampi? They will plump back up, your memory will get better. If you treat depression, it will lower your risk of developing dementia, especially if you treat those things before they get too severe. Yeah?
Does dementia cause depression, or does depression cause dementia?
Fantastic. Yes. Yeah. So, and this is what makes it so tricky, right? So depression can be a symptom of dementia, right? Depression is also a risk factor for dementia. So it's not going to cause it, but it's definitely going to raise, if you have untreated depression, it's definitely going to raise your risk. It can also mimic dementia, so it'll look like you have it when you don't. Same thing goes for sleep stuff. Sleep problems can be early sign of dementia. They can be a late sign, they can be a symptom of dementia later. They can also be a risk factor. So I think this is a great example of how all these systems are really interwoven. And this is why when people ask, if I do this, will I get dementia? It depends on about 7,000 other things that you're doing most of the time. These systems are super interrelated. And I don't know about any of you, I have yet to meet the person who's living the perfectly healthy life. So we're all going to have things that raise and lower our risks for these different things, and all we can do is try and control them as best we can. But it is good to be aware that they could be symptoms of a larger problem, or they could be a problem on their own that we need to get taken care of to reduce our risk of the larger problem. Excellent question. Any other? Okay. So let's talk about how to reverse cognitive decline. So let's say you had one of those issues that I just put up on the slides, and you need to know how to take care of it. So number one thing, medical intervention. Just going to your primary care doctor regularly, getting labs, making sure meds are taken regularly and as they should be, making sure that all of your health conditions are well controlled, treat your sleep apnea, treat your high blood pressure, treat your cholesterol. That is far and away the best thing you can do to prevent yourself from getting dementia, except not getting older, which is not an option. So, first and foremost, right? Anybody with uncontrolled medical conditions is going to raise their risk for all kinds of cognitive decline, including the dementias. There's a lot of people who refer to diabetes or Alzheimer's disease as diabetes type 3, because uncontrolled diabetes is one of the highest risk factors for Alzheimer's disease. So making sure that you're getting your checkups, making sure that you're treating things like infections, vitamin deficiencies, all that good stuff. The second is psychological treatment. So I will tell you the story of a patient I had in my office today. I saw her this year, I saw her in 2021, she saw a different neuropsychologist in 2018. She has now seen a psychiatrist. She came in and said, every single one of you is telling me I don't have dementia, I have depression. Do you think I should take an antidepressant? Ma'am, please treat the depression. She keeps coming back with cognitive complaints. It's been going on for 10 years. We're testing her. It's not a dementia process. I was able to give her very good evidence that it's not. But she still resists the fact that like treating any sort of mental health thing. She's like, well, I'm sad because I have this going on in my life, and I have this going on in my life, and I have this going on in my life. Right. If you treated it, if you felt better, things would get better. Your thinking would get clearer. Your mood would get better. You'd feel better. But people are extremely resistant to it because of stigma, because of, I think there's a lot of sort of misinformation about either the effectiveness of psychotherapy or the risk factors of taking different psychiatric medications. And certainly you want to see good providers and you want to get good treatment. But so many of the chronic cognitive problems I see in older adults is because they won't get any sort of psychological or psychiatric treatment. And then while they're doing that, their psychiatric issues are getting worse. They're continuing to increase their risk of getting dementia down the road. Certainly chronic pain management. So again, this is a really, really important thing, especially as we get older. You get pain, you get immobile, you often stop socializing, get sad. Now you're sad, you're in pain. You're also not sleeping well because the pain is waking you up. And now you've got what we call a symptom cluster. So you've got pain, sleep problems, mood problems. Those things will feed each other and sort of cycle. So sometimes for many people, managing their pain level through things like really minimal basic exercise, chair yoga, pool stuff, recumbent bicycles, PT, yoga, trying to sort of manage a little bit of the pain will then, the sad part about that symptom cluster is that it all feeds each other. The great part about that symptom cluster is when one tends to get better, so will the others. If your pain gets better, your sleep gets better. If your sleep gets better, your mood gets better. If your mood gets better, your pain gets better. So I actually was a part of a study where we put people in an fMRI and gave them pain stimulation and watched their experience of it, right? Because pain is just neurons firing. And people who are depressed truly experience more pain. So the same stimulus, the same level of shock in someone who's depressed versus not depressed will cause more pain in the depressed person. We can see it light up on the fMRI. So again, this is, if nothing else, this talk should be a advertisement for getting all your stuff taken care of. See your doctor, see your therapist, go to PT, and because all these things are so interconnected, once you can start to tackle one, you'll often find that the others get easier to tackle. And then, of course, sleep. Oh, yeah, please.
Why is there not more focus on the brain? And what I mean by that is when you have colonoscopies at a certain age and other sort of things, breast cancer, if you're a woman, other thing, you get those things checked on a regular basis. Why is there not more of an emphasis on, regular sort of what's your brain-based thing? How does everything go?
Yeah. Honestly, I don't know. I agree with you. If it were up to me, everybody would get baselined when they hit 50, and we would have a comparison for them across their lifespan. Part of it is lack of resources. Part of it is our healthcare system. So if you put baseline in a referral to me, the insurance company is going to kick it back. It has to be medically necessary. Even when you reach a certain age. You have to have a complaint. Your doctor has to say this person has a memory problem. Which then is really frustrating because then guess what's in your medical record? You have a memory problem. Yeah. But, again, I agree with you. I think as things become more accessible, I think things like CTs and MRIs and brain scans were previously very prohibitive, much more accessible now. access to testing for the different dementias, so blood tests for Alzheimer's disease, even PET scans are becoming more and more accessible for a lot of people. But yeah, it's really frustrating that you have to say there's a problem. People don't really, insurance will not cover preventative brain care. And it is very frustrating. Yeah. Sleep hygiene, sorry. So sleep quality, very, very important. I've already given you my pitch. If you want to hear more of my pitch, I can do 2 more hours after this is over. But the big things are, 1, treat your sleep apnea. I know the mask sucks. I know you don't like it. But honestly, 4 hours a night is a game changer. It will dramatically reduce your risk of heart attacks, strokes, and dementia. 4 hours a night. So even if you're somebody who rips it off in the middle of the night. Also, they're getting way better at this. So if you haven't seen your sleep medicine doctor in 4 or 5 years, they've come up with all kinds of stuff. It doesn't have to be the Darth Vader mask anymore necessarily. They have implants that will just move your tongue. I have one guy who just has to wear a little backpack, and it has a pillow on the back, and whenever he rolls onto his back, it rolls him back over. That's all you gotta do.
My daughter just got diagnosed, and she said she loves it. It's not like my brother.
Yeah, it's a game changer.
Yes, it is.
And for the people who can adjust, it takes time, right? You have to adjust to it. It takes a little time to get used to. But for the people who successfully transition to it, they'll tell you they feel 1,000,000 times better, and they're reducing their risk of so many health problems. So let's say you don't have sleep apnea. Certainly trying to make sure that you get good quality sleep is really, 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 really important for your brain health. So things like going to bed at the same time, getting up at the same time, avoiding devices and blue light in your bedrooms. I see you TV people. I know you. You insist that the TV helps you sleep. It probably does, because anything that's routine is going to help you sleep. Sleep is about routine. An unhealthy routine will help you sleep, but it will also disrupt your sleep quality. I did a study on comatose patients in a traumatic brain injury unit. And we had patients who their parents or their family members would leave TVs on while they slept. And the blue light did disrupt their sleep quality, even though they were unconscious. You still go through the sleep stages when you're unconscious. So blue light, we also found that patients, when we instituted a nursing protocol, so for patients who are unconscious and they're in the hospital, right? Nurses will come in, lights on, open doors, right? They're gonna do their thing. The person's unconscious, it doesn't matter. Those people actually recovered slower than when we implemented a policy where the nurses had to keep all the lights off, move quietly, and let them sleep through the night. It is hugely important. Again, the problem with sleep is we're not great at telling how well we sleep, right? We'll wake up and say, I didn't sleep at all. If anybody has one of these guys, you'll be like, oh, I didn't sleep at all. And then you'll look at it and be like, great job last night. And then you'll wake up the next day and be like, I slept great. And they're like, get it together. So it's really hard to self-monitor that sort of thing. But having good sleep hygiene, good sleep habits really, really helps, and as much as you can. Especially, again, because as we get older, we sleep less. We need less sleep as we get older. But we tend to sleep less. We tend to wake up earlier. For the lovely men in the room, you guys have the nice prostate issues that wake you up all night long. People have pain, right? And so engaging in as good a sleep hygiene as we possibly can is really, really important.
So on your watch, I just want to ask a question.
Yeah.
You know, the degree which they provide feedback on sleep quality, how reliable is that really? Is it really, or like, and also if it gives you an indication like, you know, maybe you have sleep apnea.
Yeah.
Are those readings actually valuable, or is it randomness?
You're just going to take me right off on a tangent, but I'm working on a grant right now for use of wearable sleep monitoring in older adults. So the answer is some things. So it's these are essentially what these are actigraphy devices. They monitor our movement during sleep. So they're really, really good at sleep time, how much time, what we call wake after sleep onset, WASO, so how much time you spend awake after you've fallen asleep. They're not as good with things like breathing and heart rate. Some of them are better than others. But they can usually certainly indicate you should probably follow up on this. And they're getting better and better every day. So they're very good at telling you how long you slept, whether you moved a lot in your sleep, whether you were awake a lot. And then the other stuff, like stages, some of them will say like, you had plenty of REM sleep. They're better than nothing. They're definitely not as accurate as like a formal sleep study. Great question.
I have no problem sleeping. I typically sleep 7 to 8 hours a night. But I get a lot of dreams, and I always, and none of them even dreams, not even, crazy.
That's great.
I don't know if I'm getting deep sleep or not.
Good question. So the beautiful answer to that is you cannot dream unless you've already gotten deep sleep. Yes. So you have to go through all the stages of sleep in order. So you have to go through stages 1, 2, 3, and 4 before you can get to REM. REM is where you dream.
And I don't remember my dreams except maybe the very last scene, before I
Yep. And you dream more and more as you go. So you get more REM sleep as the night goes on. So if you're sleeping 7, 8 hours, you probably get a decent amount of REM sleep, and you've gone through 3 and 4, which is the deep sleep, and that's how you got to the REM sleep. Yeah.
For elderly people, maybe just for men, because you had mentioned, it sounds like sleep hygiene's a hoax. Because why is it that I sleep well and my father, who's 88, says it's the worst thing about getting old is what happens when you sleep. It's hard. Every time I call him, 11 o'clock, he's taking a nap. 4 o'clock, he's taking a nap.
Yeah.
Is this just doom of aging? And he's physically in excellent health.
Yeah.
Otherwise, his heart and everything, it's just the sleep.
Yeah. So a little bit of column A, a little bit of column B. So as we age, we need less sleep. People do just wake earlier as a general rule. We do also tend to need, especially as you hit like 80s, 90s, naps do tend to become kind of more necessary. Just general fatigue happens. By the time if you ever have anybody in your life who's like 100, 101, 102, the amount that they sleep feels scary. You just need a ton of sleep. So part of it is getting older, right? You need the naps. Part of it is, again, the medical conditions. So if you're an older male, you're probably getting up a lot to go to the bathroom. If you're older and you have any sort of joint or orthopedic issues that wake you, any of those sorts of things. So part of it is just getting older. But there are ways to sort of try and maximize your sleep quality, because also by the time we hit our 70s, 80s, we can develop some truly terrible habits. So there's also a lot of people who are used to sleeping in their chair, or they sleep, they fall asleep at 5, stay downstairs till 8, then go up to bed, but they've actually already been sleeping for 3 hours. So it's a little bit of both in most people. Yeah.
I was recently with a group of big guys, sort of mid-60s up to 80, and it was amazing how many people actually use CPAPs. And
Proud of all of you.
people who weren't using them thought, I don't know, I definitely don't. Like, I do smoke. And it's like, is that becoming more, it seems more prevalent now? And I'm pretty sure my brothers or both probably should be on CPAPs, but not. Like, I'm
Yeah. It's probably,
one of those things that you do sort of test regularly and say, I probably should get this checked.
I think there's increased awareness. I think the improvement in the technology is making more people use it. Certainly we have increases in certain health conditions that may be increasing the rates of sleep apnea. We're also just living longer. But my suspicion is more and more people are using them because we're doing a better job of educating people about why it matters. 2, they're becoming less and less onerous. You can now have travel versions. You can have self-cleaning versions. You can have just the nasal cannula. You don't have to have a mask at all. So I think probably that's also helping. Yeah, but I don't know. That would be an excellent study. Any other questions about this stuff? Oh, like an app? Oh, we're talking about, do you mean to like monitor your sleep? So a lot of them have built-in stuff. So if you have a wearable, using that one, I think. I don't know that any of them are vastly superior to any of the other ones. I think my research assistant did a look into them last year or so and couldn't really find any huge differences. But again, the technology is changing all the time. Sorry, this.
I'm gonna ask, I know taking really strong sleep aids is considered an unknown. But the sleep aid aisle in CVS is full of stuff, Tylenol PM, Advil PM, Cedrin PM,
Yeah.
that stuff okay to use? Or is it-
Check with your doctor because there's different risk factors depending on meds you take, other risk factors you have. There are, there are certain risk factors that come with things like Benadryl or any of the antihistamines. Melatonin tends to be the most mild. So often you'll see, I think, ZQuil is trying to now like monetize and it's like pure sleep or something. I'm pretty sure it's just melatonin. Yeah. But check with your doctor because they will be able to tell you sort of what's safe for your various other health conditions. But generally, yes, those are going to have much less of a cognitive impact than like a sedative hypnotic. Yeah. Which again, taking Benadryl every single day does elevate your risk of some things a little bit. Certainly it's not going to cause the level of problems of like, Lunesta or Ambien, but always check with your doctor. Sorry.
Only people in this room are here because they're aware of it and asking wonderful questions. What about the people who are not in this room, who are encountering some of these problems? What is from your experience, the advice about how to raise these issues with someone who we think is encountering these problems and could benefit from a combination of all these?
Excellent question. If I had truly figured that out, I'd get yelled at way less. But I think certainly finding an in and using an entry point. One of the things that I really focus on is figuring out what the person cares about and choosing one intervention point. Because again, all these things work in a system. And what often happens is if you're an older adult, you go in to see your doctor and they're like, you need to eat less, you need to drink less, you need to move more, you need to drink more water, you need to make sure that you're socializing. Also, make sure that you're sleeping well and taking your medications. And it's like, no, it's fine. I'll only live to 80, it's fine. And so often what I find is if it's somebody who's really concerned about their cognition, then I might be able to hook them on trying the CPAP because they're really concerned about the cognition and it's worth taking care of it. Or if it's someone who says, like, my pain is the worst thing in the world, and I can hook them on, there are health psychologists who do help with pain. You can kind of get them to treat the mood stuff. So it's generally about finding buy-in from my perspective and tackling kind of one thing at a time. It's my best advice. I'm sorry, this person.
I was kind of asking the whole sleep thing. Just snoring, someone who snores, does that
It's evidence of sleep apnea. It doesn't mean there is sleep apnea. But somebody who snores regularly, it's worth getting checked out, especially if they wake up feeling tired. Sorry.
You mentioned earlier that hormone changes through menopause can impact cognition and have effects, psychological and cognitive effects. How do you feel about hormone replacement therapy to help deal with some of the changes in hormones?
I mean, there's good evidence that sometimes it can be really helpful, and that it can sort of help deal with some of the symptoms depending on the appropriateness and the person. So it's kind of individual. But yeah, it can be helpful for sort of dealing with some of the cognitive effects, at least. Sometimes when people get the hormone replacement therapy, they find that their brains get a little clearer. Hormone replacement in and of itself, I'm not aware that it can cause cancer. I do know there are certain types of people for whom it's contraindicated, right, because they have risk of something or they have a genetic risk. But in and of itself, in a vacuum, no. But obviously, always check with your doctor. If you do nothing else, check with your doctor. So the HRT, the evidence is kind of mixed, but they don't seem to be harmful. The GLP-1s, we don't know yet. They're way too new. But anything that controls your weight, controls your diabetes, controls your heart problems is probably going to be helpful. So the meds in and of themselves, who knows? But anything that helps people's diabetes get better, hypertension get better, anything like that is going to reduce their risk for cognitive problems and dementia. So we don't know a lot about the GLPs in and of themselves yet, but.
So I'd like to talk about sleep position.
Yes.
Apparently you can't sleep on your back exactly. That's why you have a pillow.
Some people, so when they roll onto their back, their windpipe closes. Not everybody.
So then the options are on your tummy, let's skip that one. Which side? The left side?
Doesn't matter. Whatever side keeps your windpipe open.
Okay, but I have a qualification there. I've been told that if you overeat and tend to have a very full stomach, there's a potential for reflux. And I've been told that if there's a potential for reflux, you need to sleep on your left side because something in the intersection that closes and makes a chance of swallowing something from your stomach less.
You have now exceeded my area of competency. I do not know the answer to that.
But you've entered my ignorance.
Guess what my answer to that would be? Ask your doctor. Ask your doctor.
I was told to sleep on your left side.
There you go.
It's more beneficial for your heart. If you go for a,
Were you told that by your cardiologist?
yes.
Okay, there we go.
Because when you do not an EKG, heart rate,
They do make you lay on your left side, yeah.
left side, because it's a truer indication of how your
Yeah.
heart's function.
There you go, left side.
No charge.
I wanted to get back to the idea of convincing someone that they need to get some help.
I mean, at the end of the day, it can't be done, right? Necessarily. I can tell you everything that's good for you, and if you are determined not to hear it, I've literally had people wait 9 months for an appointment with me, sit through a 3-hour appointment, come back, and I give them their results, and they go, nah, that's not right. I'm so glad you came in. Why did you come to see me? So to a certain extent, there's certainly people who are going to say, no, that's not me. No, that won't help. No, that's not true. And some of those people we're never going to convince, right? I think the things that we know from psychology are to be supportive, not confrontational. Try and figure out, again, start with one thing, start with something small, start with something they enjoy. So people ask me all the time, like, well, what brain games should I do? The kind that you'll do, the kind you enjoy. What kind of exercise is best? The kind that you'll do. So getting buy-in for something, whatever that is. For some people, that's kids and grandkids. Hey, don't you want to be able to go to Disney World with us? You probably should start your PT. For some people, it's engaging in hobbies. For some people, it's their other bad habits. I had a lady who would not give up the wine, like hard pass. And so we're like, well, you got to do something. So she gave up cigarettes. Do what you can do. Unfortunately, the answer is there's always going to be some people who are just going to give a no. But I would say supportive encouragement, try and do one thing at a time, try not to overwhelm them. That's kind of my best advice. and know that I have failed at it so many times. So.
Your comments on the role of alcohol with respect to sleep on the one hand and cognitive decline on the other.
Yeah. Not good for either. So alcohol helps you fall asleep, right? You're more likely to fall asleep with alcohol, but it actually it disrupts the sleep cycles. You get less REM sleep. So you may even feel like you had more sleep. But even just one drink is actually pretty good at disrupting your sleep quality. From a cognitive perspective, acutely, we all know, right? Alcohol will certainly cause you to be more confused. It hurts working memory. It hurts ability to pay attention. Again, at the end of the day, a couple drinks a week, is that probably going to dramatically change your entire risk profile? Probably not. Again, it's this sort of discussion that we were having earlier about everything's sort of this cumulative risk, right? And nobody can live a risk-free life. Either you have a genetic risk, or you have a healthcare, condition, or you have a habit, and most of us have all of those things. So yeah, no alcohol is good for your brain or your body. But that's kind of it is really bad for your sleep and your mood. But is one drink like twice a week really going to make that big of a difference? You got to figure that out for you. Everybody's kind of different. And what you're willing to tolerate versus give up. Yeah.
Can you talk about heredity and cognitive?
Yes. Okay. So this is a tricky topic because there are some things that are truly hereditary. There's one type of Alzheimer's disease that is truly genetic, runs in families only in Europe. There are diseases like ALS that are caused by genetic mutations, right? So I'm going to put those aside. If we're thinking about general Alzheimer's disease, other types of dementia, other neurological diseases like Parkinson's disease, can you have genetic vulnerabilities? Yes. Do they necessarily raise your risk more than your uncontrolled diabetes and hypertension? Probably not. So there are exceptions to that rule. But for most people, if they don't have a very strong family history, and I'm talking like every single woman in my family for 4 generations, both my parents, both sets of grandparents, the odds that genetics are going to be the determining factor are probably lower. Yeah, it's really tricky. I think we've definitely moved away from the misconception that like my mom had it, I'm going to get it. Does anybody know what the number one risk factor for dementia is? Age. If you hit 90, you have about a 50% chance, regardless of what you do. And so if you do have a family member who got Alzheimer's disease at 85, it doesn't dramatically impact your risk at 65. So the thing that I always say, everybody's risk is going to be very individual. It's going to be super multifactorial. It's going to involve 1,000 different things, all the stuff we've talked about and a million things we haven't. So generally what I encourage people to do is try and focus on the stuff you can do to reduce your risk. Genetic testing is a whole other thing that I'll come back next year.
When you read about, focus on dementia, Alzheimer's, there seems to be a large focus on amyloid plaque in the brain.
Yes.
There seems to be a very strong focus and study and research on if you remove amyloid plaque, are you reverse and are you fixed?
Mm-hmm.
I'm just interested in your comments on that.
Good question. This is actually very exciting. Am I going extremely over? Okay. So the amyloid hypothesis. Forever, the hypothesis has been that amyloid causes Alzheimer's disease. In the past 5 to 10 years, we've now created drugs that will clear amyloid from your brain, and they will not cure Alzheimer's disease. So we know now that it's more than that. Is amyloid playing a role? Probably. We now think the tau amyloid ratio, right, is probably playing a role. There's a lot of theories about vascular dementia and cerebrovascular disease. There's some people who are talking a lot about inflammation. There's a great guy named Adam Brickman. He did a podcast called Navigating Neuropsychology. If you're interested, he does a beautiful job of explaining all of this. But yes, so yes, for forever we thought that Alzheimer's disease was a single syndrome with a single pathology. We now know that that's not true because we have also discovered a clinical syndrome that looks just like Alzheimer's disease that does not involve amyloid. It's called late. And so the more that we are able to isolate the clinical pathology and test for it, the more that we're realizing that the relationships between the clinical syndromes and the pathology are not one-to-one. I have had, in the last month, 5 patients, at least, who are amyloid positive and cognitively normal. There is a certain percentage of people who are amyloid positive who will never develop Alzheimer's disease. So the relationship between the two is much more complex than we realized. It's not one-to-one. And so as an individual, I think that's really, really important to know, especially as you get into the opportunities to get, advanced biomarkers and get genetic testing and do all that stuff. The presence of amyloid may be biological Alzheimer's disease, but it does not necessarily mean that it's going to be clinical Alzheimer's disease. Navigating Neuropsychology. It's great. Adam Brickman is the doctor who did the episode. Navigating Neuropsychology. Yeah. Sorry.
What do you think of the new drugs that will remove the amyloid?
They seem like they're very promising. The initial research is really promising. They're really just being available to the general public, and so the use is really changing, right? Because up until now, everybody who had it was in a clinical trial, and the use was heavily regulated. Now so before, you couldn't get it if you were cognitively normal. You had to have cognitive symptoms. But now it's FDA approved, it's out there. There are people who are getting the infusions who are cognitively normal or who, don't have this or who don't have that. They don't fit as neatly into that box. So I think we're still going to be learning about kind of the broader implications. But the initial data was very, very promising for at least slowing things down.
You talked about untreated sleep apnea. What about untreated hearing?
Dun, dun, dun. Number one dementia risk factor that is 100% preventable. People who do not wear their hearing aids, their brains age faster than the people who do. And here's a very important trick. You have to wear them all the time. This taking out and putting in, no. We get up, we brush our teeth, hearing aids in. We go to bed, we brush our teeth, hearing aids out. And the reason for that is, how many of you have heard the, I want to say urban myth, but it's true. How many of you have heard that everybody's ears are distinct? They're different, right? Totally true. Everybody's ears are just a little bit different. And so your ears independently are funneling sound waves into your ear canal, into your brain, right? And your brain is learning to interpret those signals. When we change those signals, your brain's, no. Oh, I got to recalibrate. So for example, if the extreme example is like people who get cochlear implants, they actually have to go through like a rehab process to get their brain adjusted to the hearing, to changes in their hearing and it takes months. So imagine if you're taking your hearing aids in and out and in and out, and the stimulus that's going to your brain is changing. It's making it really hard for your brain to adjust. We also know that people who don't wear their hearing aids, even if they can hear, if they're working harder to hear, it's the equivalent of squinting, right? If you need glasses and you're sitting there and you're squinting, you can say, no, it's fine, I can see, but you definitely have a headache at the end of the day. People who don't wear their hearing aids tend to socially isolate. They won't go out in groups, right? It is by far one of the easiest, not cheapest, but easiest things you can do to reduce your dementia risk. Thank you for the segue.
The other thing I think important about hearing aids is that hearing aid technology does not stand still. And every year they come out with something more sophisticated and better.
Yep.
It might appear to be a scam, but it's real advancement that could help.
Yeah. And at this point, I mean, yeah, you can tie them into the TV. You can tie them to your phone. There's everything.
I have said to somebody, it's like telling somebody just squint harder. That's the equivalent.
And they will insist that they don't need them. But it's the same as the kid who didn't have glasses and just didn't know he needed glasses. And wearing them consistently really makes a big difference and will improve your comfort level with them and your experience of them. They will annoy you significantly less if you wear them all the time.
Can you talk a little bit more about dementia causing depression? And how would you go about even identifying that's what's happening and then treating?
Yeah, so in some circumstances, it's truly a symptom. So there's a couple different types of dementia that have depression as a symptom. So Parkinson's disease dementia, frontotemporal dementia, depression is actually like kind of a cardinal symptom of the disease, and it's very neurologically based. And it has its own sort of characteristics that you see a doctor who specializes in that, and they can kind of help you with that. But the other thing to keep in mind is if you think about someone in the early stages of like Alzheimer's disease or something where there's prominent memory concerns, it is exceptionally scary to know that your brain isn't working but not understand why, to know that you're not making the connections and trying to fill in the gaps. People with dementia also tend to socially isolate because they're nervous or embarrassed. They're afraid of somebody realizing they didn't remember something. They're afraid of not being able to come up with a word. And so I think there are different theories. We don't completely know what amount of it is related to the circumstances of going through the disease process and what amount of it is related to actual physiological changes in the brain. So the reality is I'm not sure we can totally piece them apart. But I think acknowledging that it is a symptom and a part of the disease that's worth treating. Because often what happens is people really, unless there are behavioral problems, the mood of the person will sometimes get kind of ignored. And so realizing that it can be a symptom and it's something that, can be treated, can be helpful. That's a place where geriatric psychiatrists are a huge blessing. One of the places where they are truly amazing is helping you work with loved ones or family members who have dementia processes, who have mood components that they can't engage in talk therapy, or they don't even completely understand. Working with geriatric psychiatry, they can really be helpful in terms of using some medications to help. Great question. Yeah.
One of the hardest things, I think, for persons to recognize and acknowledge they have an issue in this regard. So I have a habit of taking these online self-assessments, which I'm sure you're going to laugh at. But I must say they're enjoyable. They're short. They're enjoyable. And up to now, they've been self-affirming. I'm not claiming that this is the solution of the pill, the quintessential pill for a healthy mental health. So my pragmatic question is, do you offer single consultations, or do you work on a long-term basis, or both? And can you cover this by insurance?
Great question. So, real quick, maintaining your brain health, exercise, social support, hearing aids, medical care. Let's talk about neuropsych assessment and how it works and what to do about it. Okay, so neuropsychological evaluation can be very, very helpful in the right circumstances, not so much in others. When there are cognitive deficits that are suspected but unclear. So somebody says, my thinking is definitely getting worse. I'm definitely forgetting more and more. I don't know if it's because I'm getting older or what's going on. When we know there are cognitive problems, but knowing exactly what they are would be helpful. So differential diagnosis, right? Detection of subtle cognitive deficits. We're really good at picking up on those subtle problems. When you have really complex neurological conditions, is this FTD or depression or dementia, or is it both? Or, we spend a lot of time with our patients in a way that a lot of other doctors don't get to. And of course, we're very useful before neurosurgery. Hopefully no one has to deal with that. But before people have things like cochlear implants, deep brain stimulation for Parkinson's disease, before we chop something out if we think it's causing a seizure, people generally see neuropsychology to make sure that the surgery is going to be safe and hopefully not have major consequences. When are we not helpful? When somebody has progressed to the point where their deficits are very severe. Anybody who's really progressed, like I said, we're great at subtle cognitive deficits. We're great at pulling apart, visuospatial isn't great, but verbal is, or this isn't. When it's sort of across the board and the person is functionally having a lot of problems, we're probably not going to be super helpful. Or when there's a very clear explanation for the subjective complaints. So like someone comes in and says, I'm so foggy, I'm not staying focused. My husband died yesterday and I have untreated sleep apnea. You can come see me. I'm gonna find a problem. You're gonna have cognitive problems. And I'm gonna tell you to get some treatment for the grief and go get a CPAP and come back. And anytime somebody's in an acute psychiatric or medical crisis. So generally we'll tell people if you do suspect a delirium, if there's an active infection, anybody who's actively undergoing like cancer treatments, radiation or chemotherapy, those things cause cognitive problems. And so it's going to be really hard for us to see through that. So we usually recommend that people finish any major treatments, things like that, before they come see us. In answer to your question, most insurances will cover a neuropsychological evaluation, depending on the provider. Medicare definitely does, usually about one a year. A lot of us, or many of us, or most of us work on a consultation basis. So most people see me once and they see me for testing, then they see me for a feedback session. They don't see me again for a year or maybe never. There are neuropsychologists who offer treatment, but they usually work in different types of settings. They usually don't work in neurology and don't do this type of stuff. So yeah, most people, it's a one-off consultation. I'm gonna make it. So statistics, that's why you all came. I know. I just use this to explain how neuropsych testing works. We ask you to do something, and then we take your performance and we plot it statistically and figure out whether you're falling right in the middle there. So everybody has strengths and weaknesses, right? But compared to the average 85-year-old woman with 16 years of education, are you falling generally where we would expect, or are you falling to this lower end? And that gives us, that is what tells us, are you experiencing what's pretty much within the realm of normal experience for your age? Or do we think there's a disease process happening? Is there a problem? And based on the profile of that problem, we can usually point to what might be going on. And usually, as we've previously discussed, it's usually not that clean. It's usually more than one thing. Almost every single one of my report summaries has, the primary cause is probably this. The other factors that are contributing are, here's the list of things: sleep problems, mood, pain, all that good stuff. So just real quick, a plug for how to find a neuropsychologist. I will preface this by saying there are not enough of us. Those of us take Medicare and Medicaid. Our wait lists are absurd. But it is really, really important to see a neuropsychologist who's qualified. This is definitely an area where people will practice outside their competence. And what they will do is they will work outside a hospital system so that you can get in sooner and pay cash. But they may not have, and they don't know what they don't know. So I absolutely have had people come from local community psychologists who thought they got a neuropsych. I had one guy who was diagnosed with dementia in his 60s. It turns out he had a long-standing learning disability that had caused the test results. And the person who had tested him just didn't know any better. And so they walked around for over a year thinking that he had dementia when he did not. So it's a really good idea if you are going to see a neuropsychologist. Board certification is the easiest way. There are board certification directories. You can go online and find the board certified neuropsychologists in your area. It requires us to go through a very rigorous process. It takes time. But if you think about, like, if you were to go see a surgeon for your hand, would you really want to go and see like a general surgeon who usually does stuff on livers? Or would you want to see a board certified hand surgeon? So this is the easiest way to make sure that your provider is qualified. There are plenty of qualified providers out there who are not board certified yet. They're just harder to distinguish if you're a member of the general public. Yeah?
In an effort to not waste an individual's time, what is indicative? What would you be looking for? What would you be questioning that would say, maybe I should go and see you?
Yeah, great question.
Because, I mean, your time is valuable. You don't want to take away from someone who really, really needs you.
Yeah, I appreciate that. The best thing you can do is to make sure all that stuff we already talked about is already taken care of. So definitely making sure, I'm not in an acute psychiatric, I'm not in a I can't find an easy explanation for why this is happening. That's one. I think two is making sure that you are paying attention to the symptoms in the context of the people around you. So I have so many people that come to see me and say, all my friends have this too, but in me it's a real problem. As you get older, word finding difficulty and trouble with working memory, walking into a room, I can't remember why, can't hang on to the phone number between the phone and the notepad, most common complaints. It feels more acute when it's you, right? You were aware of what you were able to do before. And so even when other people around you might say, yeah, me too, it feels more acute in you. I think when other people mention it or notice it is a really good indicator. Hey, we talked about this.
It's kind of like hearing aids.
Yeah.
No, you can't hear me.
No, you can't hear me.
Okay, I should check.
Yep. I think, and I think there's nothing wrong with saying, you know what, I want to be seen. I just want to make sure that this is something I don't need to be concerned about, but I'm aware that I'm not an urgent case and I'm okay to wait just so that I can get my Medicare to pay for it. There's nothing wrong with that. I think there's no reason not to go and get checked out.
But to your point, rule out.
If you could rule out the other stuff before you get to us, you're going to make the visit much more productive.
Keep a log.
Honestly, kind of. Yeah, are the symptoms worse when I'm tired? Are the symptoms worse at a particular time of day? When did they really start? Did I notice them right after a particular incident, medication change, injury, all those sorts of things? As much of that stuff as you can do, it just makes your visit with us way more productive.
Touched a little bit about stress, and it's not as if we're living in stress-free world.
Not possible.
But can you talk a little bit about that, how that impacts, layers onto what's going on here? I don't know if you have strategies to deal with that.
Yeah, you're right. We can't live in a stress-free world, right? It's not possible. The best thing we can do is manage our reactions to the stress. So things like This sounds overly simple, but you will be shocked at how many of us don't do it. Pay attention to your mood. So many people move through their day-to-day life and really aren't paying attention to if they're getting more irritable, less interested in things around them. You know when you're acutely happy or acutely sad, but you may not really be paying attention to the fact that, like, when you consume all the news every day in the morning, you're starting to get grumpier and you're snapping at your wife, right? Or that when you get up and start your day with a walk, you don't do that. So definitely monitoring your mood, keeping track of that sort of stuff, and being aware of when the stress is really impacting you, because you can't live a stress-free life, right? And one of the things I have experienced with my patients and my own family, and probably some of you has, as you age, your world gets smaller. You maintain the same level of stress and anxiety no matter how much you have to worry about, right? So it used to be, we'll talk about how, my mother-in-law had four boys under 6 and was working, and her husband was gone all the time, and they were moving all over the country, and she was running around with a chicken with her head cut off. But now, she's retired, lives alone with her husband, plays golf 3 times a week, still runs around like a chicken with her head cut off, right? Maintains the same level of sort of distress and worry. It just now involves what is in her world now. And I think that's a great example of how we can monitor how we're responding to the stressors around us, and not sort of letting them kind of move us in and out of moods or throughout life without, we don't want to be reactive to everything around us as much as we can be proactive to keep ourselves not stress-free, but less impacted. There was someone else I missed. Okay.
This is going back to the hearing. What is your knowledge base about acoustic neuroma? Are there other risk factors other than if one side of your hearing is a little less than the other, they seem to rush and say, oh, you need to get a scan for ruling out acoustic neuroma. And I'm not really, I'm wondering if there are other issues, like, apparently it's a very small tumor that grows very slowly. But I was told by, wasn't an official ENT, it was practitioner, the other physician's assistant or something. And I was planning on getting another opinion before I go for an MRI. And like you said, there was a slight differentiation on the left as opposed to the right.
Yeah, I would defer to an ENT and neurologist on that. I won't comment on that. That's outside my scope.
I think we have time for one more question.
So my wife had acoustic neuroma, and through the surgery they had to remove the right ear. So she has only 1 ear. Should we be more concerned about? No.
Not necessarily. Yeah. So this is how a neuropsych evaluation works. It's not working anymore. I did something. There we go. Okay.
Cursor work?
There we go.
Oh.
To answer your question, how to make the most of an evaluation with a neuropsychologist. And one more question? Yeah. This one?
The other one?
This one? Yeah. Yeah.
Do you have a suggestion in terms of when is appropriate time to switch from a regular primary care provider to a geriatric primary care provider?
Yeah, I think it varies from person to person. I think anytime you start having issues that are very specifically age-related. So my big thing is once somebody starts to have signs of like a dementia process, I'll say, think about a geriatric provider. Anything where the issues they're dealing with are very specific to older adults. So once you start dealing with like levels of care, does the person need assisted living? Do they need, are they able, when you start seeing impacts on their functional abilities, I think at those points it's not a bad idea to think about a geriatrician.
Is there a benefit to using all the science around longevity?
think there is. I don't know for sure. I can't say for sure. I think a good primary care doctor is a good primary care doctor. And so if you don't need the specialized knowledge that's involved in diseases related to aging, I'm not sure it would make a difference. Thank you.
Thank you so much, Dr. Townsend. Thank you, everyone, for joining us this evening.